So good afternoon, everyone. Welcome to the Yale Sleep Medicine Rounds. My name is Ritika Thapa. I'm one of the pulmonary critical care and sleep medicine faculties here at Yale. Before I introduce our today's speaker, some housekeeping announcements. Please take a moment to ensure that you're muted. Please see instructions in the chat to receive CME credit for attendance and a one-time sign up for a Yale CME profile to receive credit if you have not done so yet. If you think anyone else would be interested in joining us, please reach out to Debbie. I'll be moderating this session, and if you have any questions or comments during the presentation, please use the chat or at the end of the talk, you can unmute yourself as well. Recorded versions of these lectures will be available on YouTube a few weeks after the presentation. And I have the pleasure of introducing Dr. Jeremy Orr today. He received his medical degree from Washington University in St. Louis, followed by internal medicine training at UCLA and fellowship training in pulmonary and critical care medicine at University of California, San Diego, UCSD. Dr. Orr is an associate professor of medicine in the Division of Pulmonary Critical Care and Sleep Medicine at the University of California, San Diego. Dr. Orr's research has primarily focused on sleep-disordered breathing, hypoventilation syndromes, neuromuscular respiratory failure, and long-term non-invasive ventilation. He also founded and leads the Pulmonary Neuromuscular and Assisted Ventilation Program at UCSD and co-founded the UCSD Multidisciplinary Neuromuscular Disorders Clinic, which now serves over 300 patients and is also a regional referral center. He's received numerous honors and awards and is a recipient of several competitive research grants, including NIH, and he has authored over 60 peer-reviewed publications in leading journals as American Journal of Respiratory and Critical Care Medicine, Chest, Sleep, and The Lancet. And interestingly, he had also invented a respiratory interface during COVID and is deeply engaged in medical education, mentorship, and patient-centered innovation, and has lectured extensively on sleep and ventilatory disorders at national and international conferences, and also serves on various national committees. Thank you so much for being with us today, Dr. Orr. And without further delay, I would like to hand it over to you to share your expertise on neuromuscular respiratory failure and advances in home ventilation.
Yeah, thank you. Thank you for that nice introduction. And you really did a deep dive there. That was great. So I'm excited to talk with you all about this topic. It's something near and dear to me. And this is going to be, a bit of a mix in terms of things that I think are clinically relevant, but things that maybe also are relevant from a research standpoint, which is a line that I straddle in my practice a lot. So first things first, I guess there's this disclosure slide. Hopefully you get your CME credit for this. So, first thing I want to do is outline why we're talking about this topic. And I think, when we think back to what pulmonary and critical care and sleep, which has been in a lot of ways an offshoot of pulmonary and critical care, is all about, it really starts with supporting patients with neuromuscular disease. And I always like these historical things. There's a great paper in respiratory care. I think Dean Hess is on that kind of goes through the invention of mechanical ventilation. And so these are some drawings of some early mechanical ventilator prototypes here. This is box that you can sit the patient in. There's this pump, and you can kind of pump this bellows and change the pressure in the box and ventilate the patient here. This is arguably the first home ventilator, pun intended. It's a home that's a ventilator. This is a home that has a big piston to change the pressure, and the patient sits here with this, their head basically out this modified window, which is funny. I don't think this was actually built, but these are kind of the idea that you could support people's breathing really came from recognizing that patients, specifically with neuromuscular disease, can benefit from, supporting their ventilation. And of course, this really was encapsulated during the polio epidemic when patients, went into respiratory failure from polio and ultimately succumbed mostly to respiratory failure. And that coincided with, the invention of the iron lung and the proliferation of that in the US and mechanical ventilation in Europe as well. There's a really nice book that just came out about a couple of years ago that came out about this, The Autumn Ghost by Hannah Wunsch, which you should definitely check out if you haven't. But for me personally, I got into this field and it kind of resonated with me. And And I don't know exactly why, but I will show you this picture, which is my maternal grandmother, who I actually never met. She passed away from breast cancer before I was born, but she had polio. She contracted polio after my mother was born, before her youngest daughter was born, and was this was about 2 years before the vaccine came out, and she was actually in an iron lung for several months. And she recovered, but you can see from this picture here, she used crutches the rest of her life, and was somewhat disabled. She was able to work, but was disabled, and so I think that resonated with me with this topic this is a group of patients that we have a duty to, and that we can really help. So, when you look at the history of this topic about home ventilatory support, it's really got quite a long history behind it. Home mechanical ventilation has been around since the polio pandemic epidemic. Um, but really, the first dedicated non-hospital ventilators came out around the 1970s. And this was initially mostly used to support pediatric patients. But increasingly, over those several decades, the number of adult patients using these devices also increased. And initially, this was really in patients who were, an acute respiratory failure, who failed to wean off a ventilator. But pretty soon, people realized that this could be potentially a primary therapy for patients with more chronic respiratory failure. They don't need to wait until someone has acute respiratory failure to support their breathing. And so you could use this as primary therapy. And, I think in a lot of ways coinciding with the invention of CPAP and advances in mask interfaces and things like that, there was a shift towards the use of non-invasive ventilation, and this confluence with the expansion of obstructive sleep apnea, CPAP machines, and so there's this really nice synergy that's happened in that space that has really benefited the ability to provide non-invasive ventilatory support at home. So why are we doing this? I mean, non-invasive ventilation is quite a bit of work to implement, and we should do this if we think it's going to help patients. And I think there's certainly always like more evidence, but the evidence that's available is very compelling. So if you look at patients with Duchenne muscular dystrophy, this is a cohort study out of Japan, and these are survival curves. And they looked at the survival of patients with Duchenne by era. So they had, eras where they were not using ventilatory support. Then they started using tracheostomy ventilation. They start using non-invasive ventilation. And so they compared patients, from without using any ventilatory support in the earlier era, improved survival with the use of tracheostomy, and even more improved survival with the use of non-invasive ventilation. And they compared patients that didn't use ventilation during those eras, and found a similar survival to the earlier era. So this, I think, is, potentially confounded, but I think pretty large effect. We're talking about several decades improvement in survival with non-invasive ventilation. In ALS, the story isn't maybe quite as rosy, but I think is nonetheless interesting. And this was a randomized trial. It's been 20 years now, that showed average 6 month survival benefit for non-invasive ventilation with ALS, but very heterogeneous effect. And this parallels anybody that's taken care of an ALS patient knows how heterogeneous it is. And the responses to non-invasive ventilation come with some big wins and some not so big wins. So, this was all put together in a Cochrane review a couple of years back, and the pooled effect in terms of mortality, relative risk of zero point 0.6. So big effect. Relative risk for unplanned hospital admission, 0.25. I mean, massive effect. You almost never see that. So I think, there's a lot of other evidence out there, not much randomized data, but a lot of stuff that suggests that this is something that helps patients. And, accordingly, we've seen an increase in the number of patients using home ventilatory support over time. This is kind of a funny way to display stuff, but over time, we basically see more and more Medicare beneficiaries. This is ventilators. This is number of ventilators being used these different years, and these are the different diagnoses that were being coded for those ventilators. Basically, there was an 89-fold increase in ventilator use between 2009 and 2015. This, of course, caught the eye of Medicare, not for good reasons, but because the expenditures were so massive. And I'm not saying this is all appropriate, but it certainly argues that that this is a therapy that's being used widely, and so we need to pay attention to it. So, what about this from a more global perspective? Well, what I would say is that we have a lot of work to do. And I think one of the things when I've done similar talks is to try to, beat the drum that we need to do more and catch up here a little bit. This is a survey, so this is not amazing data, and it's a very funny graph. I always like unusual visualizations, but basically, this is the estimated prevalence of patients using home-based mechanical ventilation in different countries, and they have some different years here as well. But if you look at the rate of home mechanical ventilation use in the U.S., at least this is dating back to 2012, we seem to be fairly low compared to other, first world countries. And I don't think this is because we have, fewer patients that need these kinds of therapies. One thing that I think has been really fascinating and is that this is a very exciting time in neuromuscular medicine. And there is, first of all, much more recognition of neuromuscular disease. It's been driven largely because a lot of these are monogenetic disorders, and genetic sequencing is widely available. It's inexpensive, and so we are making formal diagnoses on many patients who would have carried only a clinical diagnosis, or frankly would not have been previously diagnosed. And so that's increased the number of patients that are diagnosed with neuromuscular disease. There's also recognition that you can modify these germline mutations in different ways. This is risdiplam, which is a antisense oligonucleotide. For a while, it had the distinction of being the most expensive therapy in the world, but it basically, for patients with spinal muscular atrophy, allowed them to splice over the mutation that was causing some of the issues and really made a big impact on the disease. Um, the flip side of this is that there's a lot of stuff that's out there that there's a lot of hope going on, and a lot of different therapies that aren't quite such a home run, but a lot of patients are recognizing that these are diseases that aren't such a lost cause, and so we have a situation where there's a lot of hope and patients wanting to keep pushing forward. And then there are some cures. I mean, this is gene therapy for spinal muscular atrophy, which, we haven't seen the effects on the adult side yet because this is something that's given to very young kids, very young babies. And so, presumably this fixes the disease. We don't know how well it fixes it, and in a disease that maybe would have resulted in the kid dying, in childhood. We don't know what things are going to look like when they're 40, 50, 60 years old. And so I think the bottom line is that we're going to see more of these patients. From my perspective, this is going to turn more to a chronic disease or a disease that's maybe cured, but more likely quite manageable with the right therapeutics. And so we're going to be part of that. Just in terms of the hope and the supportive care thing, I mean, I don't know if anybody here has been following what's happening with Neuralink and some of these brain-computer interfaces, but I was on a webinar a couple months ago and I was just blown away. So Neuralink is an implant. It's implanted surgically into the brain, and it's basically like an EEG that has depth into the brain and has all these channels, and then they can decode that. And so they're running a clinical trial right now. This is a patient they have that's completed the trial and is in the trial, and he has ALS, and he has obviously tracheostomy ventilation. I don't know. I think the sound is probably not coming
I'm
across, right?
definitely happy to have anything to
So there's
keep me in
some.
the conversation.
So
We are working together to make it better.
he's talking
My
with
problem
his
is
by
that I
thinking.
enjoy the ridiculous answers
He's
it gives
talking
me.
by thinking about
Sorry, I'm being a
talking.
bit of a jerk. I'll tone it down.
That's actually his voice that he had abstracted, and now it's an AI model that he can basically think about talking, and he talks, and he can think about controlling his computer, and he does. They're robotic arms that he can operate. So I have two patients that with ALS, young patients who are waiting to enroll in this study. And they both have tracheostomies and they're quite advanced ALS, but their hope is that they can, continue living and live a good quality of life and avoid, the very feared complication of locked-in syndrome. This kind of removes that because you can still communicate, you can still move, you can still do a lot. And so we need to keep this in mind as we're, thinking about supportive care, that quality of life is ultimately what the patient feels is good quality of life, and there's a lot of innovation going on. Oh, sorry. So the premise here is that home ventilatory support improves outcomes in neuromuscular disease. There are likely to be increasing numbers of these patients, and we need to advance our expertise and innovate. So diagnosing respiratory muscle weakness, I know this is a sleep audience, but many of you have a pulmonary background. And I would say it's not straightforward. The gold standard is straightforward. I mean, you can put a catheter down into the stomach and the esophagus and stimulate the phrenic nerves and measure some pressures, and that's great. Um, but that's not something we do clinically. And it's also only for the diaphragm, harder to assess other non-diaphragmatic muscles. So what we do is we do, lung function testing and we do, some modifications for that. And I think the first thing you have to recognize is that when you're doing lung function testing in a patient with neuromuscular disease, you're measuring something different than in a patient with lung disease. In lung disease, lung is the limiting factor. And so, when you see a reduction in vital capacity, it reflects stiffness of the lung, it reflects air trapping or those kinds of things. In neuromuscular patients, the limiting factor is the muscles. And so we're actually not measuring lung function, we're measuring muscle function. And it's also very hard to get these to standardize in the same way because the whole idea with lung function testing is to reach effort independence. And so, if your effort is limiting factor, you can't really reach effort dependence. So I think that's just an important caveat to keep in mind that sometimes it's hard to interpret these tests. They don't look quite the same as a lung function testing in a non-neuromuscular patient, and we have to just I think at some point develop some new standards. It's also important to recognize that you can actually lose a lot of respiratory muscle strength before you start seeing changes in vital capacity and total lung capacity. And so, these aren't perfectly sensitive. Spirometry and lung volumes and these things are not perfectly sensitive. So we also incorporate measures of respiratory muscle strength. Now, these aren't perfect either, but I think they're pretty decent. Maximum inspiratory pressure and maximum expiratory pressure. We utilize seated and supine vital capacity. So if you see a big drop in vital capacity, more than 15% from seated to supine, that is suggestive of diaphragmatic weakness. And we measure peak cough flow. We basically have people cough into a spirometer. We measure that flow waveform, and we very simply pick the peak from that, and that's been validated as a measure of airway clearance and risk for things like pneumonia. So this is just to show, the inspiratory pressure. You don't have to know too much about pulmonary physiology to realize that if there's no flow, the pressure deviation at the mouth or at the nose or wherever at the airway opening is equal to the pressure change in the esophagus or in the pleural space, as long as there's no flow and those areas are in communication. So, it works pretty well. It's not perfect. Again, supine fall and vital capacity also been validated. You can pick whichever cutoff that you want, and make your trade-off on sensitivity and specificity. But I think 15% is a good thing to kind of benchmark. So for a lot of patients, the pulmonary function testing, with this neuromuscular kind of protocol and the context are enough to make treatment decisions. And we'll talk about that a little bit later. And then, yeah, sorry, I should just mention, I don't know my presenter view. So um, there's limitations in the setting of bulbar weakness, right? So if you can't make a good seal on the mouthpiece and there's leak, that those numbers are often going to overestimate the severity of the issue. Oh, okay. What about diagnostic sleep studies? Love to talk about this to a sleep audience. They have a limited role. First and foremost, when you're talking about a patient with neuromuscular disease as mobility challenges, coming into a sleep lab is not quite so simple, right? They often need a caretaker. They have mobility issues. Many sleep labs don't have, Hoyer lifts. They don't have hospital beds, things like that. It's challenging for the sleep lab staff. This is not their bread and butter, right? And so, it often creates a lot of commotion. There's also waiting time. I don't know what the wait time is there, but for us, if I ordered a sleep study, it's not going to happen for a little while. And when you've got a patient with neuromuscular disease, that might be progressive, waiting for several months to make a diagnosis or decide on a treatment is risky. Sleep studies are AHI centric. I can't tell you how many patients I've gotten referred to me or second opinion or these kinds of things where the AHI was 10 or something and someone said, oh, you've got obstructive sleep apnea, and that's not what they had at all. They had severe hypoventilation, and so they got put on a CPAP machine and they couldn't tolerate it at the end of the hospital or things like that. We'll talk about the titration and these kinds of things in a second. Um, Again, even if you're not using transcutaneous CO2, just because you have a normal test doesn't mean the patient's not hypoventilating, right? Because the saturation is not a great marker of ventilation. There is some upside to this, and I think, I don't completely discount that sleep studies may have some utility in that they're not effort dependent, right? So these issues with making a seal on a mouthpiece and stuff are not as much of a concern. And we have a couple patients where we've made diagnoses, based on sleep studies. And then, potential for novel metrics. So I'm really big on um, thoracoabdominal paradox, and so that's something that you can measure with respiratory belts. If you do a diagnostic sleep study, there is something that you need to be aware of as a sleep clinician, and that is that there are very distinct types of events that you see in patients with diaphragmatic weakness. Some people call these pseudocentral apneas. Some people call them diaphragmatic events. They do meet the criteria typically for central apnea, but they're quite different from other central apneas in that this is happening in REM sleep, and most of the time, patients with heart failure, things like that, it's mostly in non-REM, as everybody knows. And these are not central apneas in the sense that the patient does not have a neural drive to breathe at that time. It's that during phasic REM, of course, you have skeletal muscle atonia, except for the diaphragm and the extraocular muscles. And so if the diaphragm is weak, you see an apnea. So it's the patient's brain is sending out signals, but there's just no effector there. And so if you see central apneas during REM sleep, and especially this kind of pattern, you need to think about diaphragmatic weakness. And I'm certain in the course of your career, you'll see patients that come into the sleep lab without any prior diagnosis of neuromuscular disease that this ends up being their diagnosis. They've got ALS with diaphragmatic onset, for example. I was asked earlier about hypercapnia, and I do think that evaluating hypercapnia is important in selected patients. Getting an arterial blood gas, it's inconvenient. I mean, we can't do this at our sleep lab or even at our clinic. You have to go to the hospital for that. It's painful. Venous blood gas, not much benefit for outpatient for me because they still have to go to the lab and to the lab at the hospital because they've got to run over the blood gas lab. There's very wide limits of agreement on the venous blood gas. So we really like transcutaneous CO2. It's got very good concordance for arterial blood gas and a spot check. If you incorporate this in your sleep testing for patients at risk for hypoventilation, you can definitely get a bit more information, and see these kinds of patterns here where you've got this, unfortunately, this is in kilopascals, so just, multiply by 7.5 or whatever, but you see this patient here, this parallels the hypnogram. Their CO2 is going up, and as they go into REM sleep, it's rising substantially. So I would bet this is a patient with diaphragmatic weakness. I have to go back to the original paper to remind myself what it is, but and then you can see there's this overnight rise in CO2 here, which is interesting physiologically. Uh, the problems with TCOM is expensive. The devices are expensive. They need to be quality controlled, and it's not paid by insurance, which is I think is bananas because it's really I think pretty well validated at this point. One other thing I'll mention is I mentioned thoracoabdominal paradox. This is an early finding of diaphragmatic weakness, and normally the chest and the abdomen should move out together. When you've got a weak diaphragm, the so-called accessory muscles are doing the work, and the chest is moving out, and the abdomen's moving in as the diaphragm is getting pulled upwards. And so this is a study that looked at patients with Duchenne and this kind of paradoxical movement, which they measured using fancy video, optoelectronic video, um, was an early marker of diaphragmatic weakness. But I'm not suggesting you get an optoelectronic setup for your office, but you put your hand, you lay the patient flat, you put your hand on their chest, you put your hand on their abdomen, and you can feel this. And so I think it's a really valuable physical exam tool. I teach it to all of our fellows. It's definitely not rocket science, but we pick up diaphragmatic weakness before the lung function testing is done. Cough assessment, I mentioned this peak cough flow. We're getting a little further afield from non-invasive ventilation, but again, there's a lot of data here that you can incorporate and look at, and so we have some fellows that are looking at the features that we can extract out of these cough patterns. And there is good treatment for ineffective cough, which is this cough assist or mechanical insufflation, exsufflation. So I think a good document, if you're trying to get wrap your heads around the diagnostic kind of uh, options and strategies, is this one from ERJ in 2019. They have this nice flow chart and kind of walks you through their suggested, evaluation for diaphragmatic weakness, including unilateral weakness, which we're not going to talk that much about. And I won't go through the whole thing. One thing they do incorporate with their workflow is diaphragmatic ultrasound, and we do a little bit of this. More I think in the intensive care unit, truthfully, but you can measure the diaphragm in two different planes, and you can measure this in the mid-axillary plane with a linear probe. You can measure thickness of the diaphragm. You can measure thickening fraction and pretty good data on reliability. And then you can measure diaphragmatic excursion. So you can put the phased array probe in the midclavicular line and insonate up through the liver and look at diaphragmatic excursion under M mode. And again, pretty decent data. This is not hard. We have some portable ultrasound like Butterfly IQ in our clinic, and so we do this sometimes. Um, and we definitely have used this in the ICU to clearly show, for example, that patients' failure to wean from the ventilator is because of diaphragmatic weakness. I like to mention that hypercapnia, when we're talking about patients with chronic disease, I think has been given the incorrect treatment, which is that I often hear, oh, the patient's hypercapnic, but it's compensated. Compensated hypercapnia, so they don't have any problem, right? Is sort of the implication. So Phil Choi and his fellow looked at this with electronic record data, and they looked at patients with different degrees of hypercapnia upon hospital discharge. And what they found is that patients with increasing hypercapnia, and particularly those with arterial CO2 greater than 65, were at substantially increased risk for death over, several months. And I think they adjusted for several factors here, But this goes along with data that we have about treatment of hypercapnia being linked to better outcomes in patients with COPD, that treating people with OHS earlier is better, that they're higher risk than regular obstructive sleep apnea patients. Now, I don't know why this is. It might just be this the canary in the coal mine that, if you have a failing system that, you don't want to ignore it. And it might be that there are actual biological effects of CO2. I mean, we know that there's effects on the brain and other organs, which I'll mention in one second here. But again, when I hear compensated hypercapnia, that's just where the patient lives. My usual response is, well, not for very long. And just because the kidneys have had time to compensate for chronic respiratory failure doesn't mean the patient's not in chronic respiratory failure. Oh, this is actually data from Canada, from the Canadian Sleep and Circadian Network. They looked at patients with OSA who had varying degrees of hypercapnia, and they looked at cognitive impairment, I think by MoCA. And they found that, corrected for other factors, that the higher your CO2, the more impaired you are in terms of your MoCA. So again, CO2 probably not benign in of itself. One other thing that's very interesting is that when you look at patients with ALS, they often are very hypermetabolic. They're breaking down all of this muscle, which is terrible. But this study shows that it's actually a contributory factor to why they develop hypercapnia, that their respiratory quotient is high and they're generating a lot of CO2. So anyway, this is something that we need to be attuned to, and that chronic hypercapnia is not normal. So what's my approach to diagnosis? First of all, what's the underlying etiology? Is this a patient with ALS? Is it a patient with muscular dystrophy? Do we not know? And how are we going to figure that out? And I work closely with our neurologists towards that end. We start with neuromuscular protocol PFTs. If there's substantial weakness or restriction, and especially if there's clear signs and symptoms, we start treatment, full stop. You don't need to go on to any other testing from my standpoint at that point. If the PFTs or symptoms are indeterminate, we will get a transcutaneous CO2 spot check. If you don't have that, you get arterial blood gas. If they have daytime hypercapnia, diurnal hypercapnia, they need to be treated with non-invasive ventilation, full stop. And then we will only pursue diagnostic PSG if we're still confused or if we think there's something else going on. So I see a number of patients with alpha-synucleinopathies that have, issues with REM behavior disorder, and we'll confirm that diagnosis there. I didn't talk about unilateral disease, but we use that selectively, and we have the ability to do phrenic nerve conduction studies selectively as well. So definitely need to work closely with your neurologists. So I'm going to shift from diagnosis to treatment. A lot of things to consider when you're thinking about home non-invasive ventilation. I think first and foremost is, what are the goals of therapy? And I don't have an exact answer for this, but I will tell you obviously that trying to make people feel better is a no-brainer. If people are having orthopnea, that is something that we first and foremost try to fix. Normalizing blood gases, I mentioned my concerns about chronic hypercapnia, so that is something that we try to do as well. But beyond that, supporting respiratory muscles and minimizing excessive respiratory drive. We don't have great measurements for this, but we look at a rapid shallow breathing index on non-invasive ventilation. I can show you how we do that in a second, as a potential marker of trying to normalize respiratory drive. You have to decide on which equipment you're going to use, which mode and which interface, and whether you're going to titrate in lab or at home, what you're going to do when patients have problems with leak, with dysynchrony, what you're going to do as they advance towards daytime use and dependence, and realizing that we have these therapies do have their limitations, and at some point, many patients will fail ventilatory support non-invasively. As far as devices, I won't go through this in detail. I think most people are familiar that you kind of have two classes of devices. You've got what Medicare calls respiratory assist devices. And a lot of times patients call these BiPAP machines. BiPAP is just this term that gets thrown around for everything, right? These are respiratory assist devices. and they're, have certain coverage criteria. You can look it up. And then you've got ventilators, which have different coverage criteria and different payment model. So respiratory assist devices are paid like CPAP machines. It's like rent to own. Ventilators are paid monthly, indefinitely, as long as it's being prescribed. And so different payment model. Different mask interfaces. There's not a lot of good data, but I will tell you in patients with neuromuscular disease, I really try to avoid oronasal mask interfaces. I probably don't need to convince the sleep people of that too much, but especially in neuromuscular patients because this really limits communication, and if they can't take their mask off or things like that, it's a problem. And then modes we'll talk about a little bit more. The one thing I just want to mention is I've seen people come in on adaptive ventilation and CPAP, and even to an extent on bilevel spontaneous. And in general, those are probably inappropriate modes to be using for these patients. So first things first, backup rate. Do you need a backup rate? Not a lot of good data. This is a crossover trial in 13 ALS patients that looked at a backup rate, bilevel ST versus bilevel S, and basically found that if you use a backup rate, patients have better blood gases and fewer respiratory events. That said, there were a few patients that did worse with their backup rate, with worse desynchrony, which we'll talk about in a little bit. But in general, you should assume that neuromuscular patients need a backup rate, and you can always back off on the backup rate if you end up feeling like it's causing problems. But in general, we should always assume that they need a backup rate. And as far as titration, traditionally this was done in the sleep lab, and the AASM NIV guidance from 2010 says non-invasive ventilation titration with PSG is the recommended method to determine an effective level of nocturnal ventilatory support. In circumstances in which NIV is initiated and adjusted empirically, PSG should be utilized if possible to confirm the final settings. So I always had a little bit of problem with this because I don't think it was really well supported. And part of that is just that that was 2010. And in the meantime, we've had a number of studies that suggest otherwise. So this is probably the largest study where they took patients, most of them were neuromuscular patients, and they did a daytime titration. They had a respiratory therapist, putting on the mask and adjusting the settings and saying this is comfortable and watching them and everything. And then they did a PSG titration or a sham titration. And overall, there was no difference in gas exchange improvement. There was no significant difference in desynchrony or arousals, no difference in symptoms. They suggested in some subgroups that maybe there was an improvement in adherence for the PSG group in the people who had poor adherence to start with. Um, but overall, there was no systematic benefit. This is patient ventilator asynchrony index, and these are a lot of events, but no major difference here. Maybe a little tiny bit on a few patients, but overall pretty similar. Arousal index pretty similar between the control group and PSG group. And in fact, some people in the PSG group had more arousals. So I think it is possible to make things worse with a PSG, with a in-lab titration, as unfortunately I've seen a number of times. Well, maybe these are just simple patients and we should, maybe we don't need to send simple patients to the lab, but maybe we should send other patients to the lab. So that is reasonable thought, but again, in this small study, they looked at full PSG versus more limited respiratory polygraphy for titration. And these are people with OSA plus chronic respiratory failure. I believe most of them were COPD. And the uh, um, the difference in terms of gas exchange and pretty much every other parameter was non-significant. And so uh, even in these patients, it's not totally clear that you need, full PSG. Now you probably need some information. I'm not just saying set it and forget it, but you probably need some information, but a full PSG might not be necessary. So the newer guidelines that came out from ACCP says for patients with neuromuscular disease requiring NIV, we suggest individualizing NIV treatment to achieve ventilation goals. And they suggest a number of different options. in order to accomplish that. So really our general approach is to utilize home initiation and titration. There are a number of ways to do this. I mean, you can, just fit the mask. You can do an office titration. You could even do a pap nap, in the office. You pick some settings that you think are reasonable. We have at least some idea of where to start for people. We adjust based on comfort and symptoms. Um, in office or asynchronously, we send people home and follow up with them closely. And then we utilize some sort of monitoring, objective monitoring parameter. And there are a number of different ways to skin this cat. But what we like, because it is built in and it is just really providing a lot of information now, and it is something you can follow long term, is remote patient monitoring using device downloads, device streaming device data. And so, obviously, people that deal with sleep apnea are really comfortable with this, can monitor ongoing use, leak. But when you're talking about non-invasive ventilation devices, you really get the full gamut of data in terms of respiratory rate and tidal volumes and things like that. Percent triggered breaths versus timed breaths, all sorts of stuff. So this is on the right here is a therapy report. I mean, you'll almost never see a patient that's quite this perfect, but I've been following this patient for a long time, and he's just every night very consistent. You can dig into the individual night data and make adjustments. In some software, you can see breath by breath data, and that can sometimes be useful. In this particular instance, you can see that the breathing's pretty regular here, a couple areas where it seems like maybe there's some arousals, hard to know exactly, but looking pretty regular. We have had a few patients where we've seen patient ventilator synchrony and been able to respond to that. The nice thing with the uh, RAD devices, the respiratory assist devices, is then you can make adjustments remotely, just like you can do with CPAP. Ventilators don't let you do that. Ventilators, someone's got to go out to the house and make an adjustment because they're life support devices. You don't want somebody hacking in and turning the thing off or something. But this telemonitoring is not always sufficient, and so we have patients who have data that we really can't figure out or symptoms that we can't sort out. We will go further from that, and sometimes that includes an in-office CO2 check, but can include titration PSG. And then we've done some pulse oximetry. I think it's a little bit um, challenging to get pulse oximetry for us these days. Home sleep testing is something that we're utilizing more. Although the nice thing with titration PSG is presumably the person can be that issue can be titrated and adjusted for. So this is an example of a titration PSG here for a patient. It's actually a COPD patient, but it doesn't matter. And I like to quiz the fellows on this stuff. And since we're on Zoom, I won't put anybody on the spot. But if you want to shout out what patient ventilator dysynchrony this represents, feel free.
We have some fellows. Do you guys want to just put it in the chat or
I quiz attendings on this too. It's okay.
trigger?
Yeah, so ineffective trigger. So you can see here um, in the flow channel that you've got these nice breaths where the patient's triggering the breath, and then they are not triggering they're making efforts here and they're not triggering. And this person's not on a backup rate. But all right, what about this one? So this is auto triggering. You see all these short breaths here. Lines up actually with the EKG, I believe, if you march it out. So this is auto triggering by a cardioballistic artifact. Oh, there's leak also. Yeah. This one's more challenging, and this is a busy um, slide. So we've got the flow channel right here, and we can see there's some event here. There's a desaturation. Unfortunately, the effort bands are not uh, working real well here, but you can see that there's seemingly some effort here, an arousal, call this hypopnea. You can see the flow. It looks a little funny and it goes down pretty flat here, but this is a patient on a VAPS device. And so the inspiratory pressure is 17, expiratory pressure is 5. There's a backup rate going on. Anyway, long story short, this is glottic closure. And so this is probably a really important patient ventilator asynchrony to know. This happens in patients who are using backup rate devices only, um, or it's only manifested in backup rate devices where the respiratory drive decreases until it looks like a hypopnea or even a central apnea. But it's a backup rate device, so it should just be able to force the air right through the upper airway. But the upper airway is obstructed, and so there's no or very little airflow. And it's obstructed not by the throat, because there's a lack of effort. It's obstructed by the vocal cords that have slammed shut. This is glottic closure. It is actually viewable on ultrasound. I mean, again, this is out of the Netherlands. There's a great research there, Trina Anderson, that does a lot of work in this area. And anyway, this is glottic closure on ultrasound. The folks from Spain have looked at this a bit more in ALS and actually found that patients with more glottic closure events have higher controller gain, higher sensitivity to CO2, and a higher apneic threshold, more likely to have a central apnea than patients that don't have glottic closure. And this specific phenotype of so that's the controller gain and the CO2 response. This specific phenotype in ALS is patients that have non-bulbar symptoms, or excuse me, pseudobulbar symptoms. And these are patients with upper motor neuron type ALS who manifest this most often. Anyway, very interesting physiology. I don't know how they were able to do this study. This must have been some very dedicated fellows helping with that. Glottic closure is not the only upper airway obstruction that happens in non-invasive ventilation, and this is a nice paper where they did kind of some phenotyping with video laryngoscopy to characterize different types of upper airway obstruction, and they saw different patterns. You can definitely check out the paper, including things like epiglottic collapse, as shown here. And so there's a lot to try to understand with these patients. And the bottom line, I think, is you can't just put somebody on non-invasive ventilation and set it and forget it. In best case scenario, you put them on, they feel better, and everything is hunky-dory, and the downloads look great. But oftentimes that's not the case, and there are many things to try to sort out. And we need better tools. I mentioned, I know we're running out of time here. I mentioned ventilator mode. This is just some work that we did. There's no systematic benefit, acutely to using VAPS mode versus bilevel ST. But we looked longitudinally and we hypothesized that patients on VAPS mode, because it kind of auto titrates the pressure, would keep up, the device would keep up better as their disease changed over time. Instead of us seeing them every few months and looking at the data and saying, oh, we need to make some adjustments, the machine's already looking at that every single night. And indeed, that's what we seem to show, that basically, especially in ALS patients where things change more rapidly, the tidal volumes and pressure support and all those things looked more robust, higher on VAPS than bilevel ST mode. We also did a study looking at auto titrating expiratory pressure. This was an industry study, but basically shows that you can use these auto expiratory pressure algorithms to try to titrate EPAP. Not every patient needs this sort of thing. It's only available on ventilator devices, not respiratory assist devices. So not every patient needs a ventilator, not every patient needs this technology, but it does seem to work. And I think in some patients, it may be quite helpful. And then remote patient monitoring really is interesting as an early warning system. And so this is an example of a patient with, unfortunately, with juvenile onset ALS. She's lovely and she is totally dependent on non-invasive ventilation and does very well with it. But a couple of years ago, she was, I think her cough assist broke or something, and she had a couple uh, strings of respiratory infections. And one night she was going along, and by the afternoon she was in distress, and she actually had a respiratory arrest. And her father like bagged her, and they called paramedics and got her to the hospital, and she ended up being fine. But this is the download from the night before, the day before, and she's very tiny. So the minute ventilation here looks quite low, and she's asleep, and the respiratory rate's fairly low. But she wakes up here, and you just see this respiratory rate climbing, 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 climbing. It goes into the next day because it's past noon, climbing, and then everything just plummets here. And this is actually when her dad found her. Um, he wasn't far away. He was like in the next room. So, we haven't really capitalized on this fully, but I think there's a lot of data that's being monitored here, and maybe valuable in terms of helping to anticipate and hopefully uh, limit these kinds of issues. Maybe the last point, hopefully, no, it's two more points. Non-invasive ventilation can be used during the day. We use SIP ventilation. We can use continuous nasal ventilation through the day. And so this works quite well. I'm going to skip. We did some work showing that health socioeconomic disparities explain variable adherence to non-invasive ventilation. And then just one last point about tracheostomy. We don't use these routinely. And I think, unfortunately, a lot of pulmonologists have this respiratory failure trach reflex, and think that the only way to ventilate somebody long term is with a tracheostomy. It's obviously not true. And it's not a more secure airway. It's a small lumen. We had a patient have a hypoxic encephalopathy from a obstructed trach, a neuromuscular patient. We did not trach, but he got trached and had a mucus plug. So we really push the non-invasive ventilation until things fail, and we really only use these very selectively. And oftentimes, by the time we're thinking about a tracheostomy in these kinds of patients, we're really thinking a lot about goals of care. But we do use them selectively. That's a little tongue in cheek. Um, so this is our volume in our clinic. We're actually above. Looks like I just pulled this morning. We're above 400 patients as of last year. It's myself and another pulmonologist. He's the magenta that's helped me pick up the volume here. And I don't do this full time. I do other stuff, but we do have respiratory therapists that really are the center of the universe for this program. They're excellent. We've worked hard to get them to be able to support us. We use remote monitoring on every single patient. We utilize in-person and video visits. Our RTs will do video visits, and we have a lot of support. We have a lot of unanswered questions here. The appropriate time to initiate NIV, mechanisms by which NIV improves outcomes, if it's resting the respiratory muscles or directly CO2. How to phenotype and respond to these upper airway issues and patient ventilator synchrony. I worry about adverse effects of non-invasive ventilation, especially in the setting of concurrent heart failure, which is common in some of these neuromuscular diseases. I worry about safety. I worry about our ventilator-dependent individuals, and you saw an example of a near miss kind of thing. And then, I think we have a lot of work to do in terms of maybe the softer skills of trying to navigate NIV failure, tracheostomy, end of life, and I don't think the messaging is quite right there as of now. So I got a number of take-home points. We need to renew our interest in care of these patients. It's an interesting area. It's impactful. Muscle testing is evolving with ultrasound and other things. Compensated hypercapnia, don't believe it. It's just about the kidneys, and the kidneys don't matter. So non-invasive ventilation is the new standard for ventilatory support. Polysomnography is not routinely needed, and we can utilize these novel monitoring technologies to improve home-based care. So with that, I want to thank lots of folks that help me in this space, including Ken Chen, who's another physician that works with me, junior faculty. Crystal Hawkins is our respiratory therapist, and she's just amazing. I mean, absolutely incredible. Um, I think I would be gray. I've been gray years ago. If not for her, she really is very dedicated, has taken a ton of initiative to make this program work and really make it patient-centered, and other folks, including our leadership at UCSD. So with
Great.
that, I'll stop there.
Thank you. Thank you so much, Jeremy, for this excellent and very thoughtful deep dive presentation and sharing your expertise on this topic of your passion, which really shows and really appreciate it. And also for beautifully putting those unanswered questions, which some of the questions I had. Um, It's just a question, with the newer guidelines suggesting symptoms-based and nocturnal monitoring approaches to the early NIV initiation, which is just based on symptoms and oximetry, how challenging has it been pair-wise for you to get their NIV covered? Have you found ways around it? That's one question. And then the other question I had was, as you discussed about the various advances we have in home and, for neuromuscular disease with various devices, technologies, remote monitoring, and all the adjunctive therapies like diaphragm pacing. Any suggestions on how clinicians can use or best combine these approaches for better patient outcome, given limited resources, time factors, all these things?
Yeah. So the first point, we I think for neuromuscular disease, we for the most part adhere to the Medicare. I don't do a lot of real early initiation, and part of that actually is that if you monitor supine spirometry,
Yeah.
a lot of times patients actually do qualify. So the patient who's got an 80% vital capacity upright, who's like I'm orthopnic, yeah, they wouldn't qualify, but you lay them down, and oh my gosh, yeah, they definitely do qualify. So just from a practical standpoint, that can be helpful. I think, beyond that, I'm not convinced. I don't see mechanistically, like for ALS, for example, how it would help. For Duchenne, I'm a little bit more convinced that earlier initiation could be better, but there's just adherence challenges and stuff that I think
Right.
make it tough. So I don't know, but I don't see that as the biggest challenge, honestly.
Right.
I see the biggest challenge as being patients that don't get initiated on therapy, that don't have their therapy titrated appropriately, and who aren't monitored close enough to make sure that they're using it and that problems are being addressed appropriately. To your
Thank
second
you.
point about integrating, I don't know. I think that this is an area where you've got multiple parameters, multiple things to keep track of. And, I hate to maybe jump on the AI bandwagon, but I actually do think that what we need is like virtual agents to be monitoring over each patient. And they've got to be individualized because patients are so different in this space. So that is something we're actually working on a little bit. The problem has been getting enough data to train and things like that. But I think that is going to be the future in terms of home-based monitoring and being able to have something that's continually keeping an eye on patients that is going to help patients feel better and relieve the burden on caretakers and make it much more feasible for clinicians to provide long-term care for such a complex patient group.
Yeah, I think that's the most important, right? Like the long term. Thank you so much.
Mhm.
A few other questions here from Brandon Noakes. Why is the controller gain elevated? I think that was on the Pilates closure.
Yeah, good question. I don't know. Something with controlled breathing. I mean, ALS patients have like some ALS patients have a very high drive to breathe, and what you will definitely see if you're paying attention is that some ALS patients want massive tidal volumes, and when these patients go to the ICU, excuse me, the ICU, they're like, this patient's getting 800 cc's of tidal volume, and I'm like, yeah, that's what they want. Let's just give it to them. So there are probably some controlled breathing changes. I don't know if that has to do with, mechanical feedback being disrupted or things like that, but it's a good question.
Thank you. And next question is from Andre. Excellent talk, Jeremy. Thank you for teaching. For the spot check TCO2, how long does it take during the office visit, and how long does the probe need to remain in place?
Yeah, so it takes like 10 or 15 minutes for the thing to equilibrate. So the respiratory therapist, they go in the room before me and they, figure out what the patient is doing in terms of their treatments and they collect a lot of the information so I can focus more on kind of assessment and plan type stuff. And while they're doing that, like they'll come and talk to me before they see the patient and say, "Do you want a TCO2?" And I'll say, "Yeah." And so they'll put it on. And so by the time I come in the room, it's stabilized, and so it takes essentially no time. We'll sometimes monitor it throughout the clinic. We've had patients who come in, they're hypercapnic, and we put them on their device and make some adjustments and just to show that we are bringing their CO2 down. Um, so yeah, it doesn't really add to our clinic time.
Thank you. And next question is from one of our fellows, Karam. Do you recommend daily long volume recruitment for your patients? If so, what techniques?
Great question. There are some data on this, and it's a little afield from non-invasive ventilation, but the idea with lung volume recruitment is a couple fold. One is to maintain chest wall mobility. Chest wall restriction is actually probably a big driver of morbidity and mortality in more slowly progressive neuromuscular diseases. And the other one is just to try to, inflate the lungs and prevent atelectasis and improve short-term respiratory mechanics. We do it selectively, and to be honest with you, it's something that needs a lot more. You can always do more, right? I mean, this is the thing. You don't want to just like tell every patient you need to do, lung volume recruitment and cough assist and NIV and all these things, right? Their time is precious, and so we don't really have great metrics yet, but we do use it in patients who have issues with that, atelectasis on imaging or where we're seeing progressive restriction. But it's a great question and an area that needs more clinical investigation.
Thank you. Next question is from Clark. Clark, do you want to ask this question or should I read it?
Sure. Thanks, Sri. Great presentation. Thank you for such a thoughtful overview, Jimmy. I was wondering if you had followed or what your opinion is on some of the work being done by folks like Gordon Mitchell and therapeutic intermittent hypoxia in plasticity and in ALS patients and in terms of improving outcomes. If you had an opinion on whether that might be a therapeutic intervention down the line. And I think Sri also sort of indicated which neuromuscular populations might you consider diaphragmatic pacing? ALS, it seems to be somewhat contraindicated. I think it has been shown to worsen outcomes. And yeah.
Yeah. So as far as therapeutic acute intermittent hypoxia, I mean, I know Gordon, and actually he helped me because my friend's dog had a spinal cord injury, and so we decided we were going to do therapeutic acute intermittent hypoxia for his dog.
Oh my God, that's great.
Which actually did help, but it wasn't a game changer. We did it for a few months, but um, I don't know. I don't know the literature in ALS all that well, and I think they are running some clinical trials right now, but yeah, I don't think it's ready for prime time, and I'm not sure. I would be, I guess, a little bit surprised if it made a big impact on ALS. I'd be less surprised for spinal cord injury, but. For diaphragmatic pacing, yeah, we don't do it in ALS. There are some people that criticize the two trials that were done, um, but I think that's the best information we have at the moment. We do diaphragm pacing, and it's really for patients with high C spine injury, uh, which we don't see a ton of. I don't go to the VA, at least not yet, but um, so high C spine injury, and then central hypoventilation syndrome. So we have a number of patients with CCHS, so we have a few with acquired central hypoventilation, and so I think it's really best in that context. In patients with in muscle problem, I'd be really careful because like muscular dystrophies, the muscles can be damaged by excessive effort, and so you have to be really careful about that. In a patient with spinal muscular atrophy, for example, that's more of a motor neuron disorder, I'm not sure. I mean, I think you could make some arguments for it, but again, the ALS literature has not been supportive. So, but you know, I'm not aware if there are any other new investigations going on in that space, but I think we need mechanistically to understand more first. We seem to be missing something with ALS and neuromuscular diseases in terms of stimulating, those nerves.
Great. Thank you so much, Jeremy. That's really wonderful. And thank you everyone for joining in and hanging with us till now. Have a good day, everyone. And thanks again, Jeremy. Bye.
Thanks, all.